MBRRACE reports, along with our two rapid reports. And the rolling cycle for this year includes confidential inquiries into morbidity following repeat caesarean section, as well as into maternal sepsis deaths, deaths from hemorrhage, AFE, anaesthetic deaths, and deaths from neurological, respiratory, endocrine, and other indirect causes. We have a proposal open for those of you who wish to propose morbidity topics, and that's open until the end of December. The next morbidity inquiry will be into migrant women with language needs. I'm just going to talk quickly through the methods. The methods are unchanged from those that you're familiar with. Maternal deaths in England, Scotland and Wales are reported to us in MBRRACE and in Northern Ireland through NIMATCH, and we identify other deaths through a variety of sources, including the media and linked birth registration data. After identifying a woman's death, we seek records from the hospital where she was cared for, as well as her GP and any other relevant NHS services. Those records are anonymised and assessed by MBRRACE assessors. We bring that information together to a multidisciplinary chapter writing meeting when the main themes are drawn out for this report. I have to thank all of our confidential inquiry assessors who give up their time without remuneration and are absolutely invaluable to conducting the inquiry. Maternal death definitions, we will refer to direct deaths, which are those as a consequence of a disorder specific to pregnancy. The one unusual cause you might note amongst that is that deaths by suicide are considered direct deaths by the WHO. Indirect deaths are those resulting from previous existing disease or diseases that developed during pregnancy but were aggravated by pregnancy, and typically cardiac disease is one of those causes. Coincidental deaths are those largely caused by accidents, and deaths occurring more than 6 weeks but less than 1 year after the end of pregnancy are late deaths. Most of the results in this report present data for 2019 to 21, but for a few tables or graphs, they present non-overlapping data, and these haven't been updated this year. We have now to produce 3 separate reports, which is why you will see on the website 3 reports called the State of the Nation report. We also have a data brief, but just to make it easy for you, all of the results are compiled into one single report, which is very similar to the reports that you will be note previously. The shorter reports do not include the majority of the quality improvement recommendations. So I'm very pleased to welcome Alison, who is our new researcher, who's going to present the results for us.
Thank you, Marian. So in this triennium from 2019 to 2021, a total of 261 women died from coincidental direct and indirect causes of death, of which 41 women were considered deaths due to direct or indirect causes, which gives a rate of 11.7 women per 100,000 maternities. This graph shows the rolling 3-year average rates from 2003 to 2021 for indirect and direct combined deaths, as well as direct and indirect deaths separately.
The most important thing to note from this graph is when we exclude women's deaths due to COVID, you can see that that apparent increase becomes a static rate. And when you take out any deaths due to COVID, the rate of maternal mortality is 10.1 women per 100,000.
So this graph shows, unlike the other one, discrete triennial rates, which remains unchanged from last year's report, as we're in the middle of a new cycle. During pregnancy and up to 6 weeks after pregnancy, the leading causes of indirect and direct deaths were equally responsible from cardiovascular disorders, thrombosis and thromboembolism, as well as COVID-19. So this chart shows the number of direct and indirect deaths from 2019 to 2021, of which COVID-19 represents the single most prevalent cause of death with a rate of 2.3 per 100,000 maternities. When classified according to ICD-MM, the number of indirect deaths in total represent about 49% of all maternal deaths, including coincidental and direct. So of the direct maternal deaths, thrombosis and thromboembolism remains the leading cause of direct death, representing 1.6 per 100,000 maternities. This rate has increased from 2018 to 2020, the last report, but not statistically significantly so. Obstetric hemorrhage is the next most frequent cause of direct maternal death, followed by suicide, and then pregnancy-related sepsis, which is the fourth highest cause of maternal death, representing 0.73 per 100,000 maternities. As stated, the third leading cause of direct death is suicide. From 2019 to 2021, 16 women died by suicide during or up to 6 weeks after pregnancy, for a rate of 0.77 per 100,000 maternities. And as in previous reports, the majority of maternal suicide deaths occurred in the late period between 6 weeks and 1 year after the end of pregnancy, during which time 58 women died by suicide, representing 2.81 per 100,000 maternities. So this chart and graph show the causes and the rate of late maternal death between 6 weeks and 1 year after the end of pregnancy. And as stated, suicide accounts for approximately 19% of these late deaths. And when combined with other psychiatric disorders, including substance misuse, they represent almost 40% of all deaths occurring in this late period. And this rate remains unchanged since the beginning of MBRRACE reporting. Indirect maternal deaths represent just over half of non-coincidental maternal deaths. And in this period, COVID-19 was the leading cause of indirect maternal death, accounting for 33 deaths from March 2020 to December 2021, which is a rate of 2.64 per 100,000 maternities. If deaths due to COVID-19 are not considered, cardiac disease remains, as in past reports, the leading cause of indirect maternal death for this triennium, representing 1.6 per 100,000 maternities. It's important to note that this has decreased slightly since enhanced case ascertainment was introduced, but not significantly so. And neurological conditions are the third most common cause of indirect maternal deaths, accounting for 1.06 per 100,000 maternities. As in previous reports, there are continued disparities in the women who die. There remains a nearly fourfold difference in maternal mortality rates among women from Black ethnic and Asian ethnic backgrounds. As well, 12% of the women who died early in pregnancy, during or up to a year after pregnancy in the UK, were at severe and multiple disadvantage. As well, women living in the most deprived areas continue to have the highest maternal mortality rates.
Just to emphasize, for women who from Black ethnic groups, that's about a fourfold increased risk. For women from Asian ethnic groups, that's about a twofold increased risk.
As Marian said, this graph here shows the ongoing trend in ethnic disparities, as we're discussed in previous reports. And you can see that the Black women are at an increased disadvantage. For a mixed ethnicity women, it remains similar to the proportion for white women. And this shows a graph of the index of multiple deprivation, or based on the postcode of area of residence. And as you can see, the women living in the most deprived areas based on postcode remain 2 times more likely than women from the least deprived areas to have maternal death. These are selected characteristics of women who died from direct or indirect causes from 2019 to 2021. The majority of women were overweight or obese. As well, the majority, about 56%, had pre-existing medical conditions, and around 40% had mental health conditions. Importantly, a number of women were not asked about several social complexities, including domestic abuse, either during or previously to the pregnancy, a history of child abuse, the involvement in social services, or if they had a pre-existing or current mental health condition.
So these represent a minimum estimate of those prevalence rates.
For all cases reviewed by our assessors for the confidential inquiries, including both early and late deaths up to a year after pregnancy, the assessors assessed or reviewed the care received by these women and found that for the women who died, whose care was assessed, 14% were assessed to receive good care following the pre-existing national recommendations for various medical societies, whereas another 52% of women had identifications in their care that may have improved their outcome. For the women who had a re-laparotomy after repeat cesarean birth and who are included in the confidential inquiry into maternal morbidity chapter, 72% assessors identified that for 72%, there are improvements in care which may have made a difference to their outcome. So to conclude the results of the 2019 to 2021 inquiries, there's a statistically non-significant increase in the overall maternal death rate in the UK between this triennium and the immediately preceding triennium. And when deaths due to COVID-19 represented the highest rate of maternal death due to a single cause in both 2020 and 2021, and when these deaths are excluded, the maternal death rate was very similar between this triennium and the last triennium. Cardiovascular disorders and thrombosis and thromboembolism are now responsible for the same number of maternal deaths in the UK, followed closely by psychiatric disorders. And together, these three causes represent 38% of all maternal deaths. Substantial inequalities in maternal mortality rates persist amongst women living in the most deprived areas, as well as women from Black and Asian and ethnic backgrounds compared to white women. 12% of women who died were at severe and multiple disadvantage, and the main elements of multiple disadvantage were a mental health diagnosis, either current or past, substance use, and domestic abuse.
And we will be moving on later in the day to hear specifically about messages in relation to COVID-19. And we have a number of talks covering COVID-19 and messages concerning improving care. We also have a focus particularly on neurological deaths, as well as deaths from sepsis and in relation to hemorrhage. So important messages to highlight across those main causes of death.